Good morning, everyone. We are now live.
Good morning, and welcome to this meeting of the Maternal Health Access and Birthing Patient Safety Task Force. I'm David Seltz. I'm the Executive Director at the Health Policy Commission. I'm very pleased to welcome you all back to this meeting. Welcome task force members, and welcome to members of the public who are tuning in online to this meeting today. Thank you so much for your engagement and continued public service on this really incredible, important work. We have a really great agenda today and a lot of incredible material to share with you. And I'm really looking forward to the discussion today and to hear your thoughts and insights and input as we continue this work and research to be able to put together a publication as charged by the legislature for this task force. I'm struck by and reflecting about how much work has been done over the past 8 months through the work of this task force. We had our first meeting at the beginning of April, and here we are now, kind of at the beginning of December, and there's just been a tremendous amount of research work that's been done, but also a tremendous amount of discussions and deliberations and conversations that we've had in these public meetings and beyond that I think has just been so incredibly valuable. And so I'm excited to be able to turn after this meeting to thinking about policy recommendations and how we can turn all of this incredible work into meaningful and impactful policy insights that we can hand over to the legislature and to the public that will help improve maternity care in Massachusetts for many years to come. I'm also really pleased to be able to welcome back Dr. Alicia McGregor to this work. Dr. McGregor is an HPC board member, and as per the legislation, HPC has a role as co-chair of this task force through the executive director or the executive director's designee, and I'm very pleased to designate Dr. McGregor as the HPC's designated co-chair for this work. And she has been, as you all know, a critical voice on maternal health equity, not only here in Massachusetts, but is really a nationally regarded expert and leader in this. And so her leadership and coming back to this work at this stage, I think, is just absolutely excellent. So pleased to hand back over the co-chair reins to her to continue to lead this work as we drive towards publication and final recommendations. So with that, I'll turn it over to you, Dr. McGregor, to offer some opening remarks today.
All right. Well, good morning, everyone. And thanks so much, David, for the very generous introduction and for the warm welcome back. So it's truly a privilege to get back to the work of this task force, especially at this critical juncture for maternity care in Massachusetts, and also at a moment of both great opportunity and great challenge for healthcare access nationwide. So first, just want to offer a thank you to all of the members of this task force for your continued commitment to this work amidst everything that you already have on your plates. There's no doubt, as David said, that the work that's being done here will shape reproductive health and maternity care in the Commonwealth in the near term, in the very near term. But in addition, because of the innovative metrics and comprehensive analyses carried out by the team, I believe that this report will serve as an important contribution to the research literature and the policy discussion nationwide on the causes and consequences of OB closures across the country. Now, this is a literature that I've been very much steeped in studying and participating in for the last several years. And frankly, it's a literature that's been largely focused on rural regions of the country, and one that I believe has been rarely able to do a deep dive at the state level, like the one that we've been doing here. And the state level is where so much of health policy making happens. And I also believe that shining a light on this phenomenon in Massachusetts, a high-income state with a widely and well-insured population and a high-performing health system across several indicators, helping to unpack this question here will help us to understand why the so-called market failures in maternity care and healthcare persist even in the most research-rich environments, right? So the phenomenon of closure isn't just relegated to rural, remote areas and to low-income states. And we know this all too well, just pointing to the recent example of Mercy Medical Center in Springfield, which announced just last month that they would be temporarily suspending their maternity and newborn services, directing patients instead to Bay State Medical Center. Now, DPH is working closely with Mercy, but I mention this because it's a reflection that as we meet here today to discuss the impact of past closures, maintaining maternal health care access continues to be a challenge that providers grapple with and an ongoing and persistent challenge for the Commonwealth and beyond. So as for our agenda today, I'm excited for our team at HPC to share findings from the qualitative work of the task force, and also to discuss the preliminary findings on birth centers in Massachusetts. And I'll take a moment here to just to emphasize again the depth and breadth of the work that's been accomplished over the last 8 months. I think is incredible by any standards. So certainly bravo to the team and to the task force for pulling this work together. Also thinking back to the work plan that we set out in April, where we're at today, I think is really remarkable. So throughout the meeting today, we hope the presentations spur a conversation among us all, especially as we reach the interpretation stage and the stage of policy recommendations. So please, as usual, jump in whenever you have questions or comments throughout the meeting. There'll be a designated discussion section at the end of the meeting, but please, if comments, ideas, questions come up before then, please feel free to jump in. That's what this forum is set up for. And with that, I'd like to pass it to Dr. Alonso to offer any opening comments as well.
Thank you, Dr. McGregor. It's great to have you back. Welcome back. And thank you everybody for coming today. And I want to start first by thanking the Health Policy Commission in all of the hard work that they've been doing, first on leading the quantitative that we reviewed at the last meeting, and today the qualitative analysis and the birth center analysis that we'll be discussing today. I also want to thank the task force members, your emails, your persistence, and just your sustained advocacy that you continue to do on this topic. I want to thank our partners and of course the community leaders, because all of you get out of bed every morning, you leap out of bed because you're committed to continuing this work during this extraordinarily challenging time for families and providers and the systems that support them. And I want to sort of pause on what Dr. McGregor said, that in the face of so much wealth in all of its abundance that we have in Massachusetts, thinking about the research institutions we have, the political will that we have from the legislature, from our public institutions. We have committed providers who, despite everything, are continuing to provide the best care that they can. Even within that, we are trying to figure out these escalating pressures. And sometimes it feels like a ticking, not quite a bomb, but a ticking sort of tidal wave that's coming at us. We know that in the next few years, the persistent medical and workforce cuts are only going to get worse. The cost of living crisis is real. We can all feel it. And we know that the most vulnerable are feeling it very strongly. We know that this is impacting the growing instability in housing and transportation, and that deeply impacts maternal health outcomes. We know that the increasing social and clinical complexity of the families that are served by the maternal care system and the early childhood system are only getting worse as they're being defunded, and they're responding to the pressures that are very tangible at the moment. And these realities are not abstractions. They shape access, they influence the clinical decision-making, and they affect the safety, dignity, and the outcomes of birthing people across the Commonwealth. This morning, we woke up as Dr. McGregor said, to the reminder that Mercy is closing, and also a report in the Boston Globe on UMass Memorial and the audit that was just done on the Leominster closure. So this isn't an issue that we're just sort of churning over in this Zoom and in our work, but this is something that the public is very aware of and that the media is paying strong attention to because of the impact that these closures are having on people's lives. And that's why I think that today, looking at the qualitative trends that match to the quantitative trends, we know obviously quantitative data is critical, looking at the declining birth volumes, looking at the reimbursement challenges, looking at, this range in acuity that we're seeing across hospitals, the longer travel times. But I think we all know that numbers never tell the full story. And so being able to listen to the clinicians, the administrators that were involved in the decisions that impacted the closures, I think is going to give us a much sort of broader and deeper picture of what are we looking at. I think too, it's part of rebuilding trust. We know that we're in a deep crisis of trust between the public and public institutions and healthcare providers. And the currency of trust is relationships. And qualitative research is our first attempt at building a bridge towards relationships. So I think that our task and our responsibility today is to bring these forms of evidence together, looking at integrating the quantitative analysis that we looked at last time, integrating the qualitative analysis, and positioning birth centers within the ecosystem of care. We often look at birth centers as a nice to have. Oh, that would be nice for women who are low risk, who have high income. We really need to look at birth centers as a must have for all birthing people, regardless of where they live, of their risk assessment, and as an element of choice, of dignity, of respect, and of honoring what we know of scientific research and evidence in obstetric care. So I think as we review the findings, as we interrogate what it is that our task is and what this data can give us, we will help, as Dr. McGregor said, really shape a maternal health system in the face of the next decade of what we're looking at financially, socially, and structure-wise within the Commonwealth. So I'm so grateful for all of you for lending your expertise and your perspectives as we move towards the goal. Thank you.
Before we dive into that great agenda, we do have one bit of business to take care of, which is to approve the minutes from our last meeting in October. And since we are doing this virtually, we do have to do a roll call of the yeas and nays. We did circulate a copy of those minutes to you in advance of this meeting. So before we take up this motion, I first wanted to see if there are any comments, edits, questions on the minutes. Seeing none, I'm happy to entertain a motion to accept the minutes.
So moved.
Thank you, Lee. And a second to the motion.
Second.
Thank you. And I will call the roll and go just through each member and just say I'll call a yay, nay, or abstain. So Dr. Alonso, we'll start with you.
Yay.
Thank you. Dr. McGregor.
Abstain.
Thank you. Nashir Burrell.
Okay.
Thank you. Dr. Osipuku.
Yay.
Thank you. Dr. Price.
Yay.
Thank you. Lee Simmons.
Yay.
Thank you. And Dr. Cho.
Yay.
Thank you. And I think that is it for the members who are with us right now. And that's great. Thank you. I'll turn it back over to you, Dr. McGregor.
All right. Thank you so much, David. Okay, so at this time, we will turn it over to the HPC staff to provide an update on the report overview. So as you know, with support from several task force members, as well as HPC and DPH staff, we've been working through the report outline discussed at the June task force meeting. And in just a moment, the HPC staff will be presenting the qualitative findings from over 30 stakeholder interviews, interviews with stakeholders, experts, and advocates, and clinical leaders, and will present preliminary findings on birth centers in Massachusetts. And as Dr. Alonso mentioned, the qualitative work here is crucial as we reflect on and work to interpret both the quantitative findings that were presented in October, but qualitative work is also crucial to lifting the voices of these experts with deep familiarity of the maternity care system and of birth centers as well. So I'll now turn it over to Catherine Harrison from the HPC team that's been supporting this research to provide an update on the report outline and to share qualitative findings. So I'll turn it over to you, Catherine.
Thank you so much, Dr. McGregor. And good morning, everyone. I'm honored to have the chance to present this work to you today, along with my colleague, Jasmine Bland, who will be sharing this presentation with me on behalf of a great team of staff here at the Health Policy Commission. So as noted, the work that we have to share with you today is findings from interviews that our contractor, JSI Research and Training, conducted on the task force's behalf over the last approximately 3 months. And the goal of this presentation really is to report out to you all as fully and as accurately as possible what we heard through these interviews with stakeholders, to provide you with an additional set of data to consider as the task force works toward crafting a set of policy recommendations. As we get started, I also just want to introduce Alec McKinney, the project director at JSI. Alec led the interview team and took part in some of these interviews himself, and helped distill these many interviews into the key themes and findings that we'll be presenting today. And as we get started, I will just say and reiterate, please stop me along the way if you have a question. I will watch as best I can to note hands or people who look like they want to jump in, but please don't hesitate to just shout it out, interrupt me mid-sentence if that's what is needed. No problem at all. So as a reminder, as we saw in the previous slide, the work that we're going to be presenting today really is part of chapters 3 and 4 of the report. And the content that we are poised to discuss with you really is some qualitative information that tries to illuminate what it looks like on the ground for community hospital and birth center leaders, community providers, CBOs, and patients involved in maternity care. And these data were gathered through interviews. So I'll start with a couple of slides here at the top, just to recap for you how we approach these interviews and who we spoke with. So these were semi-structured interviews conducted with a few subject matter experts and a number of different stakeholders, which I'll describe in more detail shortly. And the HPC and JSI worked together to construct distinct interview guides for each of the different groups of participants, and of course to tailor the questions to best fit their particular vantage point on the maternity care landscape. But that said, all of the interviews gathered insights from participants on 3 key topics: the challenges facing community maternity hospitals and birth centers, the impacts of closures, and recommended policy changes to reduce the negative impacts of closures and improve the maternity care system overall. So in terms of who the interviewees were, some of the first interviews that the JSI team conducted were with subject matter experts. So we identified and spoke with one person who holds a role as an academic and a researcher who has studied and published on maternal and child health and health policy, rural health, and healthcare quality. JSI also interviewed 2 individuals with deep expertise, firsthand expertise in birth center care and operations. We also conducted interviews with individuals playing many different roles here in Massachusetts in the maternity care space, a total of 32 interviews with these different stakeholders. And on the next slide, we have a little bit more detail on those stakeholder interviews. So this gives you a sense of the specific roles of the individuals that we interviewed, where and what types of organizations they came from, and the particular number of interviews conducted. So starting with the top row, we did 19 total interviews with individuals from Massachusetts community hospitals, 8 of whom were administrators and 16 of whom were clinical leaders. And I'll just note that some of those clinical leader interviews in particular were done as group interviews. As indicated here, these individuals were from hospitals, community hospitals across the state, and included both hospitals with active maternity units and some that had closed a maternity unit. Moving down to the next rows, we also spoke with several community providers and CBOs in 2 specific regions where a closure had occurred. So we focused on the areas of Falmouth and Holyoke. These included a community health center, a few EMS providers, a visiting nurse association organization, and several other CBOs that were part of DPH's home visiting initiative sites, which provide various supports to pregnant and parenting people. And finally, we had 6 interviews with folks representing birth centers, including closed centers, centers that are actively looking to open or reopen, and the 1 open birth center currently in Massachusetts. Okay, next slide, please. So just a few final notes on the methods and overall approach before we get into the findings. As a reminder, I think we did touch on this at our last meeting, but we selected Falmouth and Holyoke as the 2 areas for a deeper set of community interviews, largely because of information that we saw in our quantitative analysis that pointed to the likely impacts of closures in those areas, and because they represented different geographies and populations. A key factor in the selection of Falmouth in particular was that it was one of the closures that was associated with the largest subsequent increase in drive times for patients. And we know that it serves a largely white but lower income population. For Holyoke, the selection was in part because the population they serve is more racially diverse than some other hospitals, and a higher percentage of their discharges are public payer insured. Holyoke also closed in 2020, as did Falmouth, but represented a different sort of geography. So we thought these 2 would make for a good kind of comparison and that Holyoke would make a good contrasting case to Falmouth. We tried with these interviews to make it as likely as possible that interviewees would be candid with us. So we took some steps to try to ensure that we got really honest, good, candid information from folks. JSI staff conducted these interviews and took notes on what they heard, but did not record them, and let the interviewees know that their responses would not be shared with the Health Policy Commission in an identifiable form. And briefly, in terms of the analytic approach, JSI cataloged and analyzed their notes by interviewee type and topic area to identify key themes, and worked closely with us to refine those. Next slide, please. So I will first share with you some findings about community hospital maternity units. We're going to start with describing the challenges that these hospital leaders told us they face in operating maternity units, and then move on to discuss the impacts of closures. Next slide, please. So just as a brief reminder, these are the 9 hospital maternity unit closures that are the subject of this report, or that are studied in this report. These were closures in the 2014 to 2023 time period, representing a reduction of about 95 staffed obstetric beds. Next slide, please. Here too, this slide is a reminder of work that we reviewed previously with you, focused on the factors that we have found were associated with the closures based on our quantitative data analysis. You all have seen this, so I won't go through it in detail, but thought it might be helpful just to recap some of the key points that we found through that quantitative work. So we found that most hospitals that closed maternity services had relatively fewer maternity discharges and lower occupancy rates for their maternity units than their non-closure counterparts. We also found, in terms of financial factors, which were commonly cited in essential service closure filings by the hospitals themselves, that closure hospitals were generally lower priced and received less revenue per case mix adjusted inpatient discharge than non-closure hospitals. And finally, we found through our quantitative analysis that closure hospitals had a higher share of publicly insured maternity discharges. Next slide, please. And here are the key themes that surfaced in our interviews with community hospital administrators and clinical leaders about the challenges they face. There are 6 key issues noted here, and I'll just briefly state them. Low volume, staffing challenges, both recruitment and retention, greater patient need, and 2 financial related challenges, high fixed cost and reimbursement levels. And I will drill down into each of these in the next few slides. Next slide, please. We'll start with
Catherine.
volume. Yes,
Catherine, if I may,
please.
before you get into the details of the qualitative findings, could I just highlight that in the summary of the quantitative findings, under the financial factors, the previous slide before this one, that the finding of closure hospitals having higher margins or higher operating margins, or potentially being more financially efficient, so to speak, is kind of a finding that is counterintuitive based on the literature, at least looking at the literature of sort of whole hospital closures. It's usually the hospitals that have negative margins and lower margins that would be more at risk of closure. And I know that that's something that we're trying to kind of unpack the reasons for here, but just wanted to put that out there as folks kind of think about interpretations or I'll wait till you finish the qualitative findings if you wanted to kind of share anything that came from the qualitative research there. But I wanted to just make sure that the group knew that that was somewhat of a counterintuitive finding.
Yes, thank you. That's an important point to note, and happy to circle back on that as we get into the conversation. Thank you.
Thank you.
All right, so I will start off with a little bit of a discussion of this theme of volume. And really, this was, I think, one of the most commonly cited challenges that we heard in the interviews. Just this issue of having a high enough volume of deliveries to sustain a maternity unit. Across closure and non-closure hospitals that we spoke with, interviewees consistently raised this problem and told us that this single factor related to volume really triggers a set of corresponding financial and workforce challenges, including not having sufficient revenue to cover costs, making it difficult to support anything but a small staff of clinicians to support the unit, and undermining quality by just the fact that there being fewer births and therefore fewer opportunities for clinicians to use their skills on the range of patients and stay as effective at treating patients with varying levels of need. Some of the interviewees talked about advertising and promoting their maternity services within the community in an effort to attract more patients, but still cited having challenges and an overall decline in their volume over a period of 8 to 10 years. In terms of the number of births needed to make a maternity unit viable, hospital leaders that we spoke with cited a few different thresholds. Some said 500, some said 1,000 deliveries. One interviewee indicated that even 1,500 births annually would not make the service profitable for the hospital. One slight variation on the theme of low volume overall was a point made by some interviewees about volume, which was the unpredictability from day to day, week to week, month to month that can occur in the maternity care space in particular, and the challenges that ensue from a staffing perspective. Next slide, please. Another overall theme that we heard in these interviews was about patient clinical acuity and level of health-related social needs, just across the board being higher. Patients being more complex than they used to be, with community hospital leaders and clinicians saying that they were seeing patients with more comorbidities and other risk factors over the past decade than they previously had. This is consistent with the HPC's quantitative analysis of trends in obstetric risk scores and serious maternal morbidity, where we have seen those rates rising since 2015. And one of the challenges that interviewees noted is that one of the effects of this is that they end up transferring a greater portion of their maternity patients to other sites that can provide a higher level of care. They also talked about seeing more patients who had had trouble accessing appropriate prenatal or primary care. And we all know there are well-documented access challenges for those services. In particular, some of the interviewees mentioned migrant populations and others that may face additional burdens in seeking care. And they also talked about the challenges of staffing and providing the social workers and other sort of supports within the community hospital that might be needed to fully serve patients with significant health-related social needs. Next slide, please. Workforce issues were also very commonly cited as challenges in these interviews, including relating to both recruiting staff and retaining them in community hospital settings. Some interviewees indicated that salaries for OBGYNs and their salary expectations may be higher than community hospitals are able to meet, coupled with costly insurance for a specialty that we know has one of the higher rates of malpractice claims. Interviewees indicated that these circumstances make overall staffing costs for OBGYNs particularly high. Interviewees also mentioned that recruiting staff of color and for hospitals located in rural areas were particular challenges. Another challenge cited for recruitment was around finding OBGYNs with the sort of the right skills and training and experience for a community hospital setting. One interviewee alluded to trends in obstetric education that may be de-emphasizing the kinds of skills training needed to ensure that newer clinicians are comfortable practicing obstetric care in lower resource community hospital settings, particularly given that such places may have smaller staff, so that a given OBGYN has fewer colleagues to consult with or to provide backup or other professional support, particularly for complex cases. Maintaining an adequate labor and delivery nursing staff was also cited as an operational challenge for hospital maternity unit leaders. And the way we understood this, because of the highly specialized nature of labor and delivery nursing, interviewees described an inflexibility or an inability to deploy L&D nurses to other hospital units if needed, and vice versa, due in some cases to negotiated union contract terms that impede this practice of floating of nurses from one specialty to another. Finally, with regard to retaining staff, the burden and burnout associated with providing maternity hospital care were cited as key retention challenges for community hospitals. These findings generally correspond with literature that has shown relatively high levels of burnout among OBGYNs compared to other specialists. And as reported in the interviews, staff burnout and morale issues stemmed from high workloads, liability stress, and overall just limited relief from the burdens of the job. Clinical leaders that we interviewed described working with significant resource constraints and heavy on-call schedules associated with the required around-the-clock staffing of maternity units as being draining and demotivating. And even in hospitals where maternity units continue to be open, interviewees indicated that sustaining a satisfied, engaged workforce is a persistent challenge. There was some discussion within the interviews on the value of including midwives in hospital maternity services, and really generally speaking across the interviews, a recognition of the tremendous value that midwives can bring, both in terms of the quality of care that they can provide and the way that they extend staffing overall and help to enlarge the capacity. Some of the interviewees did note challenges in retaining midwives within hospital maternity units, noting that the model of care that they are trained to provide may not always be a fit with the hospital obstetric environment, and that there can be some cultural clashes with midwives and OBs in a hospital unit. Okay, next slide, please. To take up the final theme that, again, certainly came up very frequently in these interviews, was the overall challenge of financing a hospital maternity unit. Essentially, we heard that reimbursement rates just don't cover the costs of running a maternity unit, particularly given the high fixed costs and low volume that we've just been talking about. Interviewees referred to both staffing and technology and other facility costs as key factors in creating a relatively high fixed cost structure for maternity care. And in comparison, interviewees indicated that payment rates are generally lower than needed, such that many hospitals are operating at least their maternity units on a low or negative margin. On the global obstetric fee specifically, interviewees raised it as particularly inadequate to cover the cost of caring for those higher acuity patients that they are now saying they are seeing more of. And finally, some of the community hospital interviewees made the point that their community hospitals are, in some sense, already at a disadvantage in commanding the highest rates from payers across all service lines than perhaps their larger systems or academic medical center counterparts, so that it's more difficult for them to cross-subsidize maternity services with revenue from more profitable service lines. Next slide, please. So that rounds out the summary of challenges that community hospital leaders raised for us in these interviews. I'll move on now to talk a little bit about what we heard on the impacts of maternity unit closures, and tell you a little bit more about what they said on that topic. First, just as a reminder again of the quantitative research that we've done on the impacts of closures, as discussed at the last task force meeting, the HPC's analysis of these 9 closures found that patients' drive times increased following a closure. This was true for both the drive time to the nearest maternity unit and the patient's actual site of care. We looked at a number of quality and care delivery metrics, but did not find quantitative evidence that closures had a systemic effect. Next slide, please. So in exploring some of these questions qualitatively, there were, again, a number of important themes that came out, including related to financial impacts, impacts on access to care and care delivery overall, and impacts related to the relationship with the community and the staff of the hospital after a closure. And I'll drill down into each of these again now. Next slide, please. The hospital leaders that we spoke with generally said that closing a maternity unit had improved the overall financial condition of the hospital. Related, and secondly, they called out that after a closure, they saw greater ability to make new investments in other services. And some said that they'd been able to invest in services that might have been high need within their community, such as behavioral health. In addition to those, in the interviews with hospital leaders from hospitals sort of surrounding or neighboring a closure, they said that in some cases, closures led to improvements in their patient volume, their ability to attract and recruit staff, and the overall financial state of their maternity units. Next slide, please. In terms of access and care delivery impacts, both hospital leaders and other interviewees really across the board mentioned several challenges. For one, many mentioned an increase in travel times for patients and the loss of the ability to receive care right there, right locally in their communities, particularly calling out this being a challenge for lower income individuals and those in rural areas where there may be less access to transportation and longer drive times already. This came up really around all parts of maternity care access, from prenatal to postpartum care. Interviewees also talked about the safety concerns of having to travel further for a delivery, Some of the community-based organization leaders that we spoke with in particular also mentioned that they sort of felt an increased pressure and strain to appropriately support birthing people in their community in the prenatal and the postpartum periods after a closure. Another issue we heard about from some of the clinical leaders that we interviewed was a general concern about the loss of continuity of care, a general fragmentation of care in the wake of a closure. That patients, for example, were coming into a hospital to deliver where that hospital and those providers had not seen that patient before, didn't have a prior relationship with that patient, didn't have access to medical records or other information that would make it easier to treat that patient. So they felt that this was a challenge that made it harder for the hospital to really provide the most appropriate care that patient might need. On the other hand, there were also views expressed in these interviews that a closure ultimately led to patients receiving maternity services in a more robust, better functioning, better resourced maternity unit elsewhere. Next slide, please. And finally, there were two frequent themes that came up in these interviews around the overall impact of a maternity unit closure on the relationships between the hospital and its community and within the hospital itself. The most common drawback or negative impact that was brought up in these interviews was a loss of trust between the hospitals and the communities. There was a great acknowledgement that the closure of a maternity unit had really detrimental effects to the relationship with the community. Interviewees said that some closures created resentment and perceptions that leaders in the hospital cared more about finances than about the quality of care and providing services to the residents of the area. Many expressed the sentiment that maternity services symbolized the hospital's connection to their local community and recognized that the loss of those services felt deeply personal to people in the area. They also noted what a toll it took on staff. And interviewees said that closures led to layoffs, redeployments, and overall demoralization. Some staff who had built maternity programs, only to see them close, felt betrayed, and teams lost cohesion and institutional knowledge. There was a real sense also that maternity units were typically a joyful place within a hospital that lifted everyone's spirits, and that staff and patients alike appreciated a maternity unit in a place where otherwise, most folks were in pretty difficult circumstances. And some interviewees reported that it even became more difficult to recruit for other departments in the hospital after maternity services shut down. Next slide, please. So finally, and importantly, as a way to round out the perspectives that we gathered through the stakeholder interviews, we looked at transcripts of the essential service closure public hearings for the closures in our sample to see what we could learn about the common concerns and impacts expressed by patients in the lead up to a closure. I'll say this was a very simple and straightforward analysis. We read through the transcripts, flagging the speakers who identified themselves as patients or residents of the community, and cataloged it at a high level, the types of comments and concerns that they expressed. And this slide shows a number of the key themes that we found in these transcripts. I'll say the bullets on this slide are in no particular order, and they were all mentioned very frequently across the transcripts that we reviewed. As you can see, many of these relate to access in one form or another. So there were many concerns expressed about drive times to other sites of care, concerns about having limited access to public transportation in the region that would help reduce the transportation burden. A number of comments made about specific populations that were losing access to an important hospital that perhaps, for example, was able to meet their linguistic needs, and other concerns around access, including access related to prenatal care and postpartum care or to a specific care model. Another, kind of very important and I think dominant theme that we saw in these transcripts was just the fear around the risk of poor outcomes and safety concerns that people felt at the prospect of having to travel further and travel to someplace perhaps that was unknown to them, less familiar, not within their local community or their typical travel patterns. That was a very dominant concern expressed by community members who gave testimony. So I will pause there. This is the final slide in this section on hospital closures. The next slide will kick us off to be a summary of the work that we've done on birth centers. And so maybe I'll just take a brief minute and see if there is anything I can clarify for anyone before we move forward.
Hi, Catherine. Thank you for the presentation. That was great. Just a clarifying question on the training for providers. You said they were inadequately trained for community hospitals. Are they overtrained or undertrained in that sense? If you can explain.
Thank you for the question. The impression from the data was that they were undertrained. So there was a sense that perhaps exposure to a more robust set of sort of basic procedural based obstetric care, and I'm going to be quickly out of my depth in terms of the details. But it was a sense that in order to practice comfortably in a community setting, you would need a sort of a range of skills that would equip you to be more or less independent across a variety of patients and the range of complexity that you might encounter, and that was a high bar, particularly for newer clinicians to meet.
Catherine, I have a question as well, and I feel a little bit at an advantage because I've looked at these slides before, so it can be hard to kind of follow along in the slides. So, but hopefully this can clarify something. So could we go back to slide 22? Okay, so on this slide, where it talks about the impacts on nearby hospitals that remained open, it struck me that these non-closure hospitals actually kind of interpreted this spike in patient volume and as sort of a boon for their finances. I think, we've seen other literature, mostly in Philadelphia County, where the remaining OB units saw a spike in volume that seemed to be kind of detrimental for outcomes and care because it was a more kind of clinically complex patient pool with a higher rate of comorbidities, and outcomes kind of deteriorated in the short term. But it looks like the hospitals nearby are benefiting from the increased volume so much. I mean, I'd be curious to see what the outcomes look like in the short term, but it's kind of an interesting thing to see just how critical volume is and having enough volume is in this context.
Yes, thank you. We noted that as well, and found it interesting. There were, by and large, few comments in the interviews that suggested that the non-closure hospitals had a lot of trouble absorbing the increased volume or faced a lot of difficulty. Not none, not, there were, I believe, a couple of cases where that concern was mentioned, but the bulk of the feeling, and many of the comments were more in the vein of that the impact was more or less positive, that they were able to absorb the volume, and found it, a net benefit to their overall health as a unit.
Thanks, Catherine. To Dr. Marker's point, I wonder about kind of the geographic context of that. Like if that were to happen in Boston, could BMC absorb, they are at divert, a lot of the area hospitals end up, having the consequence of high volume. So I'm just wondering kind of situationally in the state, how that might translate and that we don't interpret the perceived like benefits or non-impact of these as applicable across geography. That feels really important.
That is important. And I'm reminded that, and Kara or others on the team who may have other comments in this vein about some of the quantitative work that we've looked at in terms of occupancy rates, may want to jump in here. But I know that we have looked at some of those factors for across different hospitals. And take the point for sure at the very least that this may not apply in all settings.
Yeah, thank you. I did just want to jump in there and say one of the things we looked at on the quantitative side was when a hospital closed, we were able to see which other area hospital gained the most volume. So we think of patients who might have used the closure hospital as going instead to what we call the recipient hospital. And in general, those recipient hospitals had a higher obstetric risk index than the closure hospital. So that alleviated maybe some concerns on our end that patients wind up going to a hospital that has less experience caring for higher risk patients. And then I would say on the occupancy rate, we looked at that as well. Recipient hospitals did tend to have higher occupancy rates generally. That makes sense if it's the lower volume units that are struggling and more likely to close. But it's a very fair point that if you were able to predict where patients would go before a closure happened, you might want to consider how high that hospital is currently at in terms of its occupancy rate. We had the benefit of doing this after the fact, so we could see where the patients went and do that comparison. But prospectively, certainly agree that hospitals that are already strained would be less able to receive more patients.
Thanks, Kara.
Thank you. I'm sure we'll get into the volume conversation a lot very soon.
Great. All right. Well, maybe we can go ahead then to the next slide. And as I say, the next section is a summary of the work that we've done for Chapter 4 on the topic of birth centers, including what we know generally about Massachusetts birth centers, open, closed, and pending, what we know about the challenges that birth centers face in general, and what we've heard in our interviews with birth center leaders and staff. And here is where my colleague Jasmine is going to pick up and take us through the first part of this, and then I'll rejoin. Jasmine?
Thank you, Catherine. Next slide, please. Okay. This map here shows the location of past, current, and future Massachusetts birth centers alongside 2024 maternity hospitals in the gray dots. As folks know, there is one open birth center, Seven Sisters in Northampton, and we know that it has an 8-month waiting list. Since 2020, North Shore Birth Center and Cambridge Birth Center closed, although Cambridge has reopened for prenatal care and has plans to open for deliveries in the near future. Neighborhood Birth Center and Worcester Community Midwifery are in development, and 2 additional birth centers are in earlier planning stages. Next slide, please. Here we have DPH data showing counts of birth center births by location from 2011 to 2022. We see on the graph there's a peak in 2013 with 250 births between North Shore and Cambridge, followed by a drop to less than 100 births as Cambridge closed. Seven Sisters opened in 2020, and in 2022, the Seven Sisters birth volume was equal to North Shore and Cambridge's combined 2019 birth volume. In 2022, there were 117 births at North Shore and Cambridge, but 140 birth center births by Massachusetts residents. So some Massachusetts residents may be going to birth centers in other states. Next slide, please. We know that birth center births account for a very small percentage of US births, and in 2022, 0.65% of US births, or 24,000 births, occurred at US birth centers. Still, the American Association of Birth Centers cites a 65% increase in birth center births from 2011 to 2021. And as of 2022, there are over 400 birth centers in the US across 40 states and DC. Some 2017 data showed that the national rate of birth center births, which was at the time 0.52%, was almost double the Massachusetts rate at the time of 0.27%. The same study showed that Massachusetts birth center births were primarily paid for by private insurance, and Massachusetts had a smaller percentage of self-paid birth center births compared to the US overall. And you can see those breakdowns in the two pie charts on the right. Next slide, please. Okay. We have the estimated upcoming birth center capacity here in the blue table, and thank you to Nishira for sharing these with us. The 4 current and in development birth centers, Seven Sisters, Cambridge, North Shore, and Neighborhood Birth Center, have a projected total annual birth capacity of 1,130 births. We've done some math in the spirit of health planning in the green table to show what the total annual capacity of birth centers would need to be to increase the percent of births to 1, 3, or 5% of annual Massachusetts births. Next slide, please. We conducted a review of the national literature related to midwifery and birth center outcomes to understand the value of this model of care. Midwifery care is associated with improved patient and newborn outcomes as well as lower spending. Birth center births are associated with lower rates of C-sections, assisted births, and episiotomy, decreased use of pharmacologic pain relief, decreased use of oxytocin, and higher patient satisfaction. Birth center prenatal care is also associated with lower rates of low birth weight and preterm birth. Next slide, please. So for the next few slides, I'll share some of the challenges with birth center startup and operations and sustainability, as well as some of the recent Massachusetts policy changes that have aimed to ease some of these burdens. So we saw in the national literature that birth centers may face a number of startup and operational challenges related to licensure, the resource-intensive nature of this model of care, and workforce. The licensing requirements in particular vary by state, but again, this is focusing on the national literature for now. In some states, state and local licensure laws such as medical director requirements and hospital transfer agreements can become barriers for birth centers to open. This is something that can also be made challenging by limited familiarity with birth centers among those with whom birth centers need to build relationships and partnerships. Credentialing and licensing can also become financial barriers with fees, and birth centers are often in home-like settings, and some licensing requirements may require birth centers to take on significant upfront costs to ensure the physical environment meets said requirements. So to address some of these concerns, DPH has modernized freestanding birth center licensure regulations following the August 2024 maternal health legislation. And that includes eliminating the requirement that birth centers be under the supervision of nearby hospitals, updated staffing standards to no longer require directors be licensed CNMs or physicians, and eliminating the requirement that birth center staff be available on premises 24/7, which allows for some remote on-call staffing during off hours. Next slide, please. Regarding operational challenges, the midwifery model of care followed by birth centers is time and resource intensive with a focus on patient education and support. The prenatal appointments may take 3 to 4 times longer than a traditional prenatal appointment, and I'll discuss some financial implications of this in a later slide. We know that the healthcare system is facing a workforce crisis, as Catherine mentioned, and midwifery is also affected. There's a low supply of midwives, particularly midwives of color, to staff birth centers. And for folks interested in the midwifery workforce, I would recommend some of the work the HPC has previously published on the topic. Specific to birth centers, the median salary of nurse midwives is lower at birth centers than the median overall salary for nurse midwives and NPs. And the same study found that nurse midwives at midwife-owned practices had lower average salaries than their peers working at physician-owned birth centers. In response to some of these challenges, Massachusetts has created a board of registration of midwifery, and a licensure pathway for certified professional midwives. And Massachusetts is also creating a licensure pathway for lactation consultants. Next slide, please. Okay, this next slide focuses on the national literature as it relates to the financial sustainability of birth centers. The average birth center facility fees are less than half those of hospitals, and birth centers lack some of the negotiating power that hospitals have. Some birth centers cite Medicaid as having low reimbursement rates and chose not to contract with Medicaid due to the low rates. And as mentioned on the previous slide, the midwifery model of care is particularly time and resource intensive, and the global payment, which Catherine mentioned earlier, does not always account for this type of care. Birth centers can also offer services such as lactation support and childbirth education that are not always covered by all payers, and they may need to find other sources of funding to cover these sorts of services. To that end, as folks know, Mass Health began covering doula services in spring 2024, as well as coverage for CPM services. And Mass Health also has reimbursement for CNMs at parity with OBGYN reimbursement for the same care. Next slide. In the event of a hospital transfer from a birth center during labor, birth centers may see a reduction in their reimbursement, which can be challenging given the resources they may have already invested in that birth. And we found one study that found mixed perspectives on patient demand. Some birth centers may not be able to serve all the people who are interested in their services, while others may struggle to attract interested people. Some patients may feel safer at a birth center, while others may feel safer at hospital. And I'll flag that marketing services can be expensive, especially for birth centers with limited funds. So that concludes the sustainability piece of the literature review that we did and some of the policy changes that have happened. I'll pass it back to Catherine to discuss some of the findings from the qualitative work related to birth centers.
Thanks, Jasmine. Next slide, please. So as Jasmine said, to get into the interview findings a bit, as a reminder, we spoke with 8 individuals affiliated with Massachusetts birth centers over 6 interviews. And on this slide, we have shown the key themes that emerged from those conversations. Very consistent, as you will see, with some of the work that Jasmine just shared from the national literature. The key challenges that came up related to starting up general operations and sustainability. And interestingly, some of the challenges here kind of parallel what we heard from some of the hospitals, but there are some unique issues as well. So getting into each of these themes in a little bit more detail. Next slide, please. There were a variety of issues in the overall space of financing for birth centers that came up in these interviews. Financial strain was really the most commonly cited challenge that we heard. Many birth centers reported nearly prohibitive startup costs in particular, noting that building or renovating a facility to meet the required standards is costly, and also pointed to the cost of insurance and supplies as a challenge. They reported really that only birth centers that can manage major fundraising or that can be or owned by a hospital really can open. If they manage to open, these interviewees talked about low payment rates as a threat to sustainability. This appeared true on both the facility fee side and the provider side of the reimbursement. We did hear that Mass Health generally pays favorably to commercial payers, but still not enough. And in terms of the global fee, birth centers felt that it disadvantaged them because of their overall model of care. Again, harkening back to what some of what Jasmine just shared. The lack of pay parity for midwives versus OBs was also cited as an issue, particularly under commercial contracts. Another key theme that came out from these interviews was, for birth centers, the complexity and challenge of navigating insurance. Complex, inconsistent reimbursement policies were cited as major obstacles, and interviewees cited claim denials, slow payments, and administrative burdens that disrupt cash flow and discourage providers from sustaining birth center models. They noted that while hospitals might have reserves that can cover some of these payment issues and tie them over, birth centers said that as smaller organizations, they simply don't have that ability. Next slide, please. Birth centers also talked about facing significant challenges related to staffing. Many noted that they just don't feel they are able to compete with the compensation packages offered by hospitals or health systems, and said that as a result, it's not unusual if you work at a birth center to have at least one other job as well. They noted that the overall burden on staff who are working at a birth center is very high, that nurses and midwives face long hours and significant on-call demands, leading to burnout and turnover. And here too, the topic of training for birth center staff also came up with some comments around the challenge of recruiting staff who were really prepared and trained appropriately to work in a community setting. There was one comment about certified professional midwives, perhaps having the best or the most appropriate training to staff a freestanding birth center, and noted that the licensure process for CPMs is still getting up and running. Next slide, please. Finally, there was really an important set of comments on the general theme of the ongoing dominance of the hospital model of maternity care. And this came up in a couple of ways. For one, birth center interviewees with experiences at hospital-based birth centers or hospital-based midwifery care talked about feeling a lack of support, a lack of investment from hospital leadership, and a lack of influence over institutional decisions in that context. And second, there were some comments generally about a lack of recognition in the policy environment related to maternal health, indicating that the state has made some progress, but has been slow to really invest in birth centers, and that there has been too little progress yet toward pay equity. They also called out a need for more workforce investments to support a more robust workforce of midwives, both CNMs and CPMs, and said that overall there remains a lack of visibility and particularly a lack of public education about midwife-led models of care. So that is the final slide that we have on all of this qualitative research and work. Hope that this has been helpful in terms of providing some more information and data for you all to consider, task force members, and be happy to, again, take any questions you have or otherwise support the conversation that you may want to have from here. Thank you so much.
All right. Thank you so much, Catherine and Jasmine. Those were both very informative presentations. So it looks like we've arrived at the discussion section a little bit earlier than anticipated. So hopefully we can refer back to some of what was presented in the slides and maybe even refer back to some of the quantitative findings that might come to mind from the October meeting that folks might want to bring up now or have any questions about or comments about. So at this moment, Dr. Alonso and I would like to open it up for questions and discussion. I don't see Dr. Alonso in the box of faces.
I'll speak so that I pop up.
Okay, there you are. Okay. All right. Sorry about that. Okay. So, all right. Well, why don't we first, Dr. Alonso, did you have anything that you wanted to pull out before we opened it up? Or should we just open it up and see where folks want to take it?
I'd love to open it up and see how people are reacting to all of this.
All right.
I have a question.
Yes.
I think in Jasmine's presentation, was it Jasmine? You said that patients were concerned about the safety of birth centers. Do we know what proportion of patients that deliver at birth centers, like proportion, are transferred to hospitals for more additional care? And do we know if those who deliver at birth centers, like the outcome rates, is it comparable to hospitals? Just so we can make the case that birth centers are actually safe.
I don't have that data right now, but I can look into that and get that to you. I think that the transfer rate wasn't particularly high or a majority of patients, and the outcomes were positive. But I think in some of the patient preferences literature review that we did for chapter one of the report, we did find that patients through media and through conversations with family and friends might have different opinions just based on the stories that they're hearing anecdotally rather than through the quantitative quality information. So that is also driving some patient choice.
Yeah, I want to just chime in. Thank you, Jasmine. As a birth center director, I feel seen by that last presentation and really appreciate all of the effort that went into that. A couple things I can share some data about transfers for neighborhood birth center. We are building in a 20% transfer, but that includes antepartum, intrapartum, kind of all, and then a very low number of emergency transfers. So about, 5 to 7 emergency transfers out of 300 births per year. I think the other thing, there is a lot of work to do around safety and narrative, I think. So, this is the work of like reintroducing midwifery to the community and remembering that, the history of midwifery and how we got here to a system that advantages hospital obstetrics over community-based midwifery. There's one thing I wanted to just, because narrative is so important, there was some language in the presentation around like resource intensive, the midwifery model of care being resource intensive. And I think that I feel a little sensitive to that language. And I think that there's like a really significant ROI on that. And so I think I want to just make sure that as we're framing that, we're not kind of just leaning into like, this is a very, the minute you go resource intensive, the system is like, well, we can't afford that. Right. And so I think that's what we're seeing in hospital closures for sure. So I think there's a way to talk about the midwifery model of care and the resource investment related to the really significant ROI on community-based midwifery. So that's just like a narrative thing that kind of stood out to me for a possible reframe on that investment.
All right. Great. Any other thoughts that jump out? Any of the results presented here surprising, or were they for the most part expected in terms of the themes? Lee Simons?
Thanks. I think maybe I'll echo some of Nashira's comments, and it's validating to see what we've been hearing from the hospitals come through in the qualitative the what we've been hearing anecdotally come through in the qualitative research that you all have been doing. And thank you for that. And I wonder, as the chairs in the group start to think about recommendations, it seems to me, across settings, there are definitely common themes around workforce needs and reimbursement needs, and wondering how we'll use those findings to start or to continue to inform some recommendations we may have as a group.
Right, absolutely. To answer on behalf of how I've been thinking of this, certainly when it comes to reimbursement, I think it's clear that we currently have a very kind of volume-based payment system for maternity care. It's very sensitive to the number of patients who are coming through the door in labor and delivering. It does not currently adequately account for the fixed costs, the high fixed costs that are required to provide maternity care. And we hear that echoed over and over in the literature and also in this work. And so thinking of reimbursement models that are appropriate for lower volume settings that may be low volume, but are still crucial, they're still necessary, and there has to be a way to pay for that 24/7 coverage that's needed and the equipment that's needed. So we are thinking through these, and in terms of workforce, that is less my area. I would have to, well, defer to everyone here on the task force and Dr. Alonso and others. So just to let you know that definitely the themes of reimbursement and workforce are coming through. Dr. True?
Well, thank you. I just have a question about I think when in the presentation on the birth centers, that one of the challenges I believe that was raised was about this relationship with hospital institution. And I'm wondering, can you elaborate a little bit on what are some of the specific, is it about having a relationship with a hospital for transfers? Is it having that relationship for higher risk births in terms of how to deal with it at the birth center? I'm just curious about what are some of the concerns around that and the challenges or also solutions that are maybe raised by the interviewees.
Nashira, did you want to chime in? Oh, well,
Yeah,
I was going to turn to our birth center expert.
great idea.
No, please go ahead, Catherine. I'm chewing on that one.
Yeah, I'm sure you have better firsthand knowledge than I will. But yes, I think some of the challenges that I mentioned in the presentation that we heard in these interviews was a little bit around the role of midwives within a hospital setting or a birth center that's operating within a hospital. That there might be some kind of relationship challenges, that the model of care that the midwife model, which may include taking a little bit more time with patients, seeing patients more frequently, might bump up against the demands of a hospital environment where they want to, making sure that they're able to see as many patients as possible. So that is sort of what I was alluding to. But I would welcome other comments. I'm sure those are not the only challenges that relate to this question of the relationships between birth centers and hospitals.
Yeah, Dr. Huang, can you repeat the end piece of your question again for me?
Sure. I think my end piece is, to what extent is that relationship crucial with hospitals for a birth center to operate, right? If you have a high risk birth, let's say, do you have to have, maybe that's my question. Do you have a relationship established with a hospital for those transfers? Since I think you did mention that you are kind of predicting or projecting maybe 20% may need to be transferred. So I'm just curious about how does that work, and and is there a challenge in creating that relationship with the nearby hospitals?
Thank you. Yeah, I went a couple different places because this has really changed with the legislation that was passed last year, right? When we were first buying our property here in Roxbury, the state regulations required actually a signed transfer agreement. So we first had to go to the area hospitals, identify a transfer partner, and then decide where to buy property and build the birth center. So we were proximate. I think, we would do that anyway to be proximate, for safety planning. But I do think, it differs by state, and certainly there are geographic parts of this state, where you'll have a longer distance of transfer. So in that legislation last year, we removed the requirement for a signed transfer agreement, and what that has meant for us, and I think for future birth centers, is just that I can broker one relationship with a particular OB and leadership at a hospital, and if that OB leaves, the future of the birth center is vulnerable, right? It really shouldn't be just based on singular relationships. And so that has now changed with the new regulations. But I do think that, certainly planning for safety, and that, the CABC is the national accrediting body that does have, some guidelines around, safety protocols and transfers. So I think it does look different in each state. I think certainly relationships are at the center of it. So, there's, the legal requirement for a hospital to accept a transfer in EMTALA, and there's also the priority that we have around, one, that transfer happening, really safely and with good relationships, so that the transfer client doesn't feel like there's a failure. There's like a lot of framing around that as a failure. And I think really wanting to make sure that this is just what is needed and that feels trusted. And that one of the reasons why, we prioritize really working with Boston Medical Center is because they have a really strong midwifery unit. So the idea is that you can transfer from community midwife to hospital midwife with ease, and that not all transfers will require, transferring into emergency OB. So the relationship is very important, and how that gets brokered, I think, does really rely on relationships, even though that's no longer in the regulation.
Thank you. Dr. Alonso?
To add to that is that from the perspective of implementing the maternal health law at DPH, when we designed the community birth and doula integration program, one of the 6 pillars of that is transfer of care. And so we've done already 10 transfer drills, and we're working with hospitals and community birth providers. That includes both birth centers and community midwives on and also EMS, and just figuring out what are the places where, as Nashira says, the experience of transfer for both the patient and those who are transferring the person or those who receive the transferred person are damaged, and that of course puts not just the emotional safety, but also the health and safety of the birthing person and their child. I think though that what we're circling around here, which came up over and over again through what we looked at today, both in the qualitative research and in the birth center section, was this issue of cultures of birth. And, on one hand, we have the workforce complaining about burnout and overwork and hospitals on diversion, and there's too many patients and they're too complex and they're too acuity. And to Nashira's point of don't call it labor intensive when a midwife is spending time with the birthing person and their family, figuring out how to connect them to services, how to get them to term, and how to connect them to parenting in general and all of the support services. So I think what comes up for me as we look at this is sort of, we all look at the event of birth from the lens of different aspects. We're looking at it through the financing, through the workforce. But I think one of the really important things that this brings up for us is some people think that birth is a transformative life event that is beautiful and is remembered forevermore. Some people think it's a way to make the bottom line in your hospital. Some people think it's something that's incredibly dangerous that could go wrong at any minute. And putting all of those perspectives on the table, I think, are essential to understanding. When we look at, was it a big deal to the local hospitals that one of the hospitals closed? Oh, well, then they got more volume, and so they were more available to make their bottom line. I'm wondering how the nursing staff feels about that, about having 12 more patients a day or a week coming in their doors, and if they feel that it was a good idea that hospital closed. And again, I mean, we know that the experiences of families, that comes up all the time, of having to travel more or change care in the middle of your pregnancy is not a positive one. So I think really thinking about how does one's perceived culture of birth, or how does an institutional culture of birth impact our assessment of these findings and our digestion and analysis of these findings, is going to be really important when we shape the recommendations.
Absolutely. Absolutely. And on that note, why don't I suggest another discussion prompt, which is, how do the findings presented here really align with task force members' experience of the maternal care landscape? What did you think of some of the key themes presented overall? I know Lee touched on this a bit. Okay. Yes. Is it Dr. Price?
Thanks. It sort of answers your question. I think what I've really been thinking a lot about during this presentation and then the one back in October is Massachusetts is about to promulgate regulations around levels of maternal care. And I know right now we don't have publicly available information about what levels each of the hospitals are, But what we do know is that none of the level 4s have closed, and we actually don't have any current level 3s in the state. So we know that the hospitals that have been closed are levels 1 and 2. And I think it really does reflect what the data shows. So these tend to be smaller volume hospitals, more in rural, but I'm not really asking a question, but I'm thinking as we're heading towards implementing levels of maternal care and it's being regulated across the state, I think we need to pay special attention to the level 1s and 2s, because I think those are the ones that seem to be most at risk for all the factors. And so maybe there's a way that we can actually be proactive and think about this as we do implement levels of maternal care.
Yes, thank you very much. Anyone else have any thoughts on how the findings more or less comport with or seem a little bit surprising based on your own experiences? You know, I can't help but bring up the finding of operating margin again, because I think it was just really striking, because you would expect the so-called financially healthy hospitals to be the ones who would say, okay, well, we do have a little bit of margin. We can, we can keep maternity open. We can keep this vital service open for those who need it. But instead, and this might be a bit of a cynical interpretation, but it seems like those financially healthy hospitals, even though I guess they're lower volume and maybe level 1 or 2, they're saying, well, let me get rid of this money loser before it gets us in any further trouble. And then the qualitative results that these hospitals seem to be in better financial shape. They could use these funds, the funds that were going towards maternity, on something else. And it just feels like it's just such a relief for these hospitals to get rid of maternity. And I think that it's clearly very troubling that the ways that we pay for maternity puts hospitals in this sort of financial situation in the first place. So just bringing that up again. Lee?
And thanks for raising that. And I do feel the need to just be a little careful with that, because while they may have better margins, no hospitals have great margins right now. And so, that's all relative. And I just want to be cognizant of the really precarious financial situations all hospitals across the Commonwealth are in right now, in particular with the, impending, and I mean to say that with the as much doom as possible, but the impending Medicaid federal cuts.
Right, that's right. Thanks for adding that in. Nashira and Dr. Alonso, I don't know if the hand is a new hand or if it's the same hand from before. Okay, all right, Nashira.
Thanks. Yeah, I'm thinking about, there was a piece of data that Jasmine shared about like the sustainability of birth centers being reliant on either philanthropy or hospital ownership. And I think, to your point, Dr. McGregor, like birth centers, because of the startup costs, and like we have seen, all right, let me just be very clear. We have seen hospitals in the Commonwealth divest from their birth centers, 2 in the last 4 or 5 years. And so I think that while Cambridge is slated to reopen, when we talk about the cost of midwifery and maternity care in general in hospitals, it seems to me unlikely that the future of community midwifery is hospital-owned birth centers, right? Because of the costs that we're talking about, and because of the way that they're losing, the bottom line with maternity care. So there's something to go back to about how we think about the sustainability of birth centers, and lean into the policy and the state financing that will support community birth centers led by midwives and in the future by CPMs. It feels to me very unlikely that the future of the number of birth centers that I'd like to see in the Commonwealth, a dozen in the next 10 years, will be sustainably led by hospitals. So I just wanted to go back to that point and see if we can, like, I don't know that we're making a recommendation there, but it feels to me like we're saying one thing about hospitals closing maternity care and then saying birth centers, I can't remember what the language was, but could sustain if they were hospital owned. I think that leaves birth centers really vulnerable, and I think it also it feels to me like we're trying to redress a system that has historically advantaged obstetrics over midwifery, and then looking to that same system to actually invest in midwifery is just like a really big shift. And so I'd be happy to talk more. I can't remember that exact narrative point, but I'd like to go back to that at some point.
Yeah, that's a really excellent point. I'm trying to think back to that slide as well, and I don't know if Catherine's still on the line and could pull it back up, but what I'm remembering from that slide is that there were explanations from interviewees that said that those birth centers that were more likely to be financially sustainable were the ones that were hospital owned.
I might have said it myself in my interview.
You might. I was wondering. So that sounds like.
Yeah, it's where we go when we think about, like, this is really vulnerable work to be leading nonprofit community birth centers that rely on philanthropy. So I certainly might have said it, and it comes up. This would be the circle that I'd want to interrogate that with a little bit, right?
Well, this reminds me of sort of a piece of the reimbursement story that was around the transfers, right? So if let's say a birthing person labors and kind of does most of that in a birth center setting, but then a complication comes up and they have to be transferred. The payment in that scenario, as far as I understand, is that the hospital that they're transferred to gets that payment. If not all of that payment, a majority of it. I don't know if birth centers would get anything at all in that case. And so that's a real loss for all of the care that the birth center has provided in that episode of care, so to speak. And so I think it points to another one of the major flaws in maternity payment system that is very much volume based and centered around the location of, well, some aspects of it. I don't want to get into the global payment part now, but centered around sort of that delivery and where that delivery happens. And, I think that there are other options, other policies that are being proposed in different settings that are at the federal level. I know there's a proposal in the Senate by a couple of senators from Washington State and New Hampshire to implement a program that would include standby capacity payments, which is a proposal that's floating around in some rural settings. To keep rural hospitals, rural obstetric units open, where, it would be a mechanism that would help cover the fixed costs that these facilities face and are often not reimbursed for. So I think, certainly that piece around the ways that hospitals are advantaged in the reimbursement story, especially higher volume hospitals, might be leading us to this belief that hospitals need to be the ones to run birth centers when under a different payment scheme that wouldn't have to be the case.
It makes me think, and again, we can take this conversation offline if there's more interest to talk about it, but it makes me think about, like, a hospital community birth center partnership that's not about ownership and also, like, power, but is about investment and capital partnership, and that seems to me like another like a third way. And I'll just name one of the challenges right now on the kind of policy landscape is that when hospitals make capital investments and put money into the DON fund, that fund is limited from going back to community-based clinical settings, right? So it can go to community-based public health and other things, but can't actually go to a community birth center. So there's like a little bit of that would be one way to think about some capital support coming from hospital systems to birth centers. But and I understand why that limitation is, but there may be a way to think about partnership, licensure, something that is different than ownership. So
Definitely. Lee?
Just on that point, and it's been a while since I've looked at the DON regulations. But I wonder if there's something we could recommend to change there. And or there's also the statewide fund, which I believe the commissioner has the ability to identify what the priorities are. I know they certainly historically, like substance use disorder has been one. I don't believe maternal health is another, but maybe that's something that the statewide fund could look at too, particularly when we're talking about, more less urban communities where there are fewer hospitals to receive that have direct DO1 dollars to provide to communities. If there's not a hospital in that community, for instance, maybe the statewide DO1 funds are something to look at.
Most definitely. And definitely exciting to be thinking creatively around how to sort of adjust various policy levers, so to speak, to address this question. But that brings me to kind of the last discussion prompt that I have here, which is, are the findings that we discussed today, are they enough to go on to make policy recommendations to create a financially sustainable maternity care system, which includes hospital-based obstetric care as well as birth centers? And that creates a system and sustains a system that's equitably distributed, where birthing people are able to get the appropriate level of risk-appropriate care. Do we have enough to go on, or is there other evidence that's needed for us to make sound recommendations?
I'll go first. I think we have most of what we need. It's just one little thing that keeps bugging me. It all sounds like most of the issues are financial, you know, low reimbursement for public payment payers, high salary demands, and all of that. But I'm not sure I have a clear sense of what the major cost drivers are, right? In terms of what are these main cost factors that are the hospitals are sort of dealing with. It may be that we did talk about the salary demands and all, but I think there might be more that we don't fully understand. And if we could dive a bit deeper into that, it may be helpful when we come to make recommendations.
Absolutely. So more detail on what these high fixed costs are that hospitals are facing, and that birth centers are facing and would face as well. Right. Yes, Dr. True.
I'm having a hard time on my button. Sorry about that. I was just thinking about the narrative, right? Is it that in terms of all the findings that we've seen is pointing toward that there is a general decline in births. So volume is not going to get us out of the situation we're in terms of, and then is our narrative really about this, that the way to solve it is, like Dr. McGregor says, not through volume, but a different source of funding? And is it around, do we need more information about what type of birth centers would be taken care of? That is a necessity, right, for the community. I'm just kind of still in my mind trying to wrap around kind of like this allocation of like low risk versus a high risk birth. How do you communicate the message to the public that birth centers are where should go, could go? I think there's that messaging around that also kind of raised almost like the banner, just like we need to fund birth centers. And I think that need right now, I feel like is not that loud versus just thinking about, oh, maybe these volumes just need to be pushed to other community center hospitals versus I don't know what I'm being clear, but that's where my mind is thinking at right now.
Yes, thanks so much for that. So thinking through the volume question and how to potentially move away from volume-based payments, and also thinking through how we might shift the narrative, or maybe what information we would need, what research we would need for maybe a marketing campaign around the importance of birth centers and the safety of birth centers and the positive outcomes that come with birth centers and midwifery care.
Yeah, that will be because we are saying patients are actually much sicker now, they have more comorbidities. That kind of shifts the argument that patients should be going to more high acuity hospitals than birth centers. So I think we may need to reframe it as appropriate selection of the right patients for birth centers. So how do we do that? How do we show that certain patients will be better served in the birth center versus going to a hospital? And that is sort of the messaging that we should be thinking about.
We've certainly thought a lot about marketing and narrative, so we'd be happy to talk about that another time. I think we can look up if there's updated data, but what I have in my head is that 85% of the births that happen in hospital are low risk and could be tended to by midwives outside of the hospital in a community setting. So I think having that as an anchor point, like, and I think the thing we're always saying is like, this is about integrating community midwifery into the healthcare system, right? We are so glad to be opening, surrounded by all of these hospitals where we have these relationships and can have transfer protocol and run drills. And the majority of births can happen safely outside. And I think also just to the conversation earlier about hospitals that can absorb volume, the question that I get asked often is like, is neighborhood birth center a threat to area hospitals? And the truth is, and we talked about volume, and this may not help our argument. And I appreciated that first slide about like the birth center volume we'd need to get to like 3 or 5% of the state births. But we will do in a year what one of the large Boston hospitals does in a week, and we will take the lowest risk clients. And so there is a way that all of the hospitals in the area are really eager for us to open and say, yes, take those like low risk vaginal deliveries that are, in and out, and continue to, transfer those who need the care and who are high risk, as well as, all of the ultrasounds and PD and like everything else. So there can be a symbiotic relationship. And I think that the challenge to any argument that we're making about integrating birth centers will be if we're doing a either or versus a real conversation about integration. And I think in a place like Massachusetts and where we have so much rich healthcare, it really has to be about integration on policy, insurance, and transfer and relationship level.
All right, great. Well, if there are no further comments, I think we will transition to sort of the wrap-up portion of the meeting. And I'll turn it over to Dr. Alonso if she has any closing remarks at this time.
First, I want to thank all of you for spending your morning with us together looking at this. And the second thing I think is sort of the call to action for the next, for the holidays as you take space, hopefully for your family and loved ones, is to really think about Dr. McGregor's question of, are we ready to jump to recommendations, or do we need more time to digest all of this data? And how do we weave together the answers that we've gotten from the quantitative and the qualitative search, and if there's more questions that are coming up, which could be recommendations. We need more information about costing. To Godwin's point, we absolutely lack clarity on how much does it actually cost to run a level 1, level 2, or level 3, level 4. And I think those are important questions to know if they can be answered, because I think up until now, it's sort of been like, well, it kind of depends. And I think the other piece too is to think about, as we do move towards recommendations, is to be very aware of where we are in history right now. I think Lee's point of the impending Medicaid cuts, the investment in the Rural Transformation Fund that will be happening over the next decade, which doesn't complement what we're going to be losing for Medicaid, but does offer an opportunity. I think definitely thinking about how do we shift a culture towards greater acceptability towards the midwifery model of care, whether or not people give birth in a birth center, but knowing that it is part of the ecosystem of birth, and we need to improve access to the care model, pregnancy or birth or in the postpartum period. And then I think too, the last point is just to think about what is our responsibility from where we are. I think this task force was very carefully planned. Each one of you are here for a very specific reason. And so I think thinking about what is Chia's recommendation towards this data? What is the Betsy Lehman's recommendations towards this data? And each one of you to really think deeply about that, I think would be not, leaving you with homework, which is I'm not a great fan of homework, but that would be that would be how I'd want to close this one up. And just thank you all for your continued commitment. And thank you, Dr. McGregor, for coming back and for leading such a great session today.
Thank you so much, Dr. Lonzo. I really appreciate it. All right. So I want to echo Dr. Alonso in thanking all of you for your participation today. To summarize, the HPC staff have now presented findings from all analytical chapters of the task force's report. We're pleased to share that drafting of the written report is underway, incorporating member feedback from previous meetings. And we'll share the slide with meeting members after we adjourn. And we ask that you please continue to share any additional feedback via email so that your feedback can continue to be incorporated into the drafting process. Now, after the analytical chapters, the next step is the discussion of policy recommendations, which we've begun a bit today, that will stem from these findings. We're working to schedule a meeting in late January to discuss policy recommendations, and we'll follow up with members on their availability. And following discussion of recommendations, members will then have time to review the draft report before our last meeting held in person, which will probably be in late February or early March, where we will release the final report. And with that, thank you very much, everyone. And at this time, we will adjourn this meeting.